Good morning, everyone. To those who are present with us today and anyone observing, I'd like to welcome you to Alpha Kappa Alpha Sorority Incorporated Gamma Omega Chapter's celebration of Women's Health Month to our Girl Talk. My name is Kay Gage. I, of course, am a member of Gamma Omega Chapter, and I will serve as your mistress of ceremonies today. I'd like to now turn it over to our president, Mrs. Lanita Blackman, who will extend greetings to you at this time.
Good morning. First off, I'd like to say thank you for joining us today to talk about a subject that obviously, as women, are near and dear to our hearts. As we all know, our health journey begins from the moment that we're born. But as my grandmother would say, our womanhood began on the day that we started our period. So I know that sometimes this is a subject that is embarrassing to talk about, even amongst our friends. And so hopefully the presentation today will alleviate some of that if you are having any, and also help you to understand more about our bodies as women and the amazing things that come from being a woman. And so with that, I say thank you to our presenters, thank you to our committee chairman, and thank you to our MC for hosting this event today.
Thank you, President Blackman. And so now I want to introduce one of our speakers today. She is no stranger to the St. Louis area as she is a native of the Lou. And I want to introduce to you all Dr. Joyce Balls-Berry. Dr. Berry is an associate professor of neurology at Washington University School of Medicine and core leader for the newly established Health Disparities and Equity Core in the NIGHT ADRC. Completed her formal education at Xavier University at Louisiana with graduate training at Washington University School of Medicine and the University of Toledo. She completed a postdoctoral research fellowship in health equity, epidemiology, and biostatistics at the University of Florida. So you know she is well-versed and well-educated. Her work as a scientist centers on increasing awareness of the importance of community patient engagement in research to increase health equity in minority and under-resourced communities. Recently, she completed a PCORI project to expand the efforts of the Minority Women in Research Network, which she established in 2011. The network's mission is to promote community patient engagement in research conducted by minority women and scientists interested in research collaborations, academic scholarship, innovation, and dissemination. She is somebody you need to know. Recently, she shared her story of living with dyslexia and handling personal challenges as a TED Talk. Like her mother, she is a member of Gamma Omega Chapter where she was initiated. I'd like to again welcome Dr. Balls-Berry.
Thank you so much, everyone. And I am delighted to be back in my home chapter. My mother just celebrated becoming a 50-year member of our wonderful sorority, and she's also a life member. So she is, I am a third generation AK. And so it is a delight to be here. Kay, would you like for me to introduce Minerva, or would you like to introduce her as well? Because we're going to be tag teaming on our talk today.
My apologies, not that she was forgotten. I just didn't. Let me just be very honest, you all. I follow scripts. I do. And then I get off when I get warmed up, but it's still 10:10 in the morning. And so it's a little early. So I'll warm up. Let me tell you, but I don't want to keep you all longer because many people on this site know me. They know I can talk. And so I'm trying to respect people's time, but I'll go ahead and introduce our other presenter. Our other presenter is Minerva Orianna. She's a first-generation college student and Salvadorian American. She grew up in San Francisco Bay Area. She completed her bachelor's in physiology and master's in cell and molecular biology at San Francisco State University. It was during her master's that she became interested in studying health disparities. She is currently a PhD student in the clinical translational science track at the Mayo Graduate School of Biomedical Science. She's a big wig too, you all. Her thesis work focuses on using a translational science approach to address uterine fibroids in women of color, namely Black, African American women, and Hispanic Latinas. Post PhD, Minerva plans to continue working in decreasing health disparities in the Latinx community. I present Minerva Orianna.
Thank you again. So Minerva is one of my mentees, and she is a delight to work with. And when I transitioned from Mayo Clinic after being there for almost 9 years, Minerva is still working with my lab here at WashU. So she has a dual relationship with both Mayo and WashU. So I'm going to go ahead and share my screen, and hopefully this will work. I'm not on mute. My mother thought I was on mute, so you all probably will hear her in the background as well. So, all right, so the title of the talk today is Real Girl Talk, period. And most people call me Dr. Joy in the professional sense, and Minerva is also here. And so I always have to start with the things that the federal government likes for me to do, which is stating my disclosures. My financial relationships are listed on one side, and my non-financial relationships are listed on the other. You're welcome to read those. And if you have any questions about my financial relationships, I'm happy to share those after the presentation today. Minerva does not have any relevant disclosures to share at this point, but one day I hope that she has a ton of them to share as well, because that means that she's doing some consultant work outside of her lab. So our plan is to provide an overview of the uterus. We will review menstrual health. We'll talk a little bit about menstrual cycle changes, and we will even describe some of the key points for uterine fibroids. And then we'll distinguish other potential health concerns that are related to women's health. And then at the end, I have a call to action to support women's health for each of you. So what is our menstrual health? As the president of Gamma Omega stated, it starts with our periods. So it's very important, even prior to having our first period or menses, that we know our bodies. We know when we have pains, we know if there's a change in our appearance. And then once we start having our periods, we also must know when there are other changes that happen around our menstrual cycle, our monthly cycles. Our menstrual health relates directly to family planning, whether or not we choose to have children or not to have children, when our bodies may be ready to become pregnant, or if there are concerns around our fertility and our reproductive health. It goes back to the power that we have that lies in the fact that we know our bodies enough to ask questions of our healthcare teams, and even of our loved ones who are like our mothers or our sisters or cousins, or even other women around us who have gone through certain changes with their bodies as well. So this slide here depicts the female reproductive system. And as you can see from the slide, we have what we call fallopian tubes. And then underneath the fallopian tubes on either side are our ovaries. And our ovaries is where our egg reserves are shared or stored. And then as you go down the diagram from the ovaries and through the uterus is where a baby would be housed. And then this tissue right on the edge is called the endometrium. And so the baby would go through the cervix, and once we release, we would shed, once an egg is released through the fallopian tube to become pregnant and the sperm enters, then we would become pregnant, and all of these other wonderful things happen. But if we do not become pregnant during our cycle, then the lining would shed and the egg would be released through our vagina, and we would have our monthly periods. So what is the menstrual cycle? It relates to hormonal changes that occur in our bodies of biological females. So those that are born female at birth. The menstrual cycle is also called the period, and it is part of puberty. When our period starts, it's called the menarche. I do live every day with dyslexia, so there are times when I may pronounce things very differently, so just chalk it up to my brain. So things always change with women's health. In our childhood, we don't have periods, but right around the age of 12 is when puberty starts. And this is usually when some women experience their periods. Now remember, this is an average. So some young women will experience them earlier and some may experience them later. The rule of thumb is by probably 15 or 16, if a young woman has not had her period, then it usually is important to talk to your healthcare provider to find out if there might be some other hormonal things that might be going on. So once we start having our period, as we go through this cycle of changes with our estrogen levels, which is one of the hormones that women produce, the average age of having childbirth is a little over 30 years. Now, there are some women that give birth to a baby prior to 30, and then there's some women like Janet Jackson who give birth at 50. So it goes the spectrum. So right around between the ages of about 45 to about 47, there's another period that is not, or another phase that is not depicted on the slide called perimenopausal stage. And that's when women may start having some changes in their periods. They may not come as frequently, or there might be changes in the length. There might also be other changes with their health and how they're producing estrogen, which would then lead into this phase called menopause. And once we hit menopause, we're in menopause forever. Menopause typically starts around 52, a little over 52 years. And this is the phase where women are typically no longer have babies. But if you watch the news more recently, there was a woman that just gave birth at 57, and that's not that common. So what's normal? So every woman we must know our bodies. So on average, most women's cycle, which is this circle here, it's the days that we have in the month before our menstrual period, is typically on average about 28 days. But some women's cycles are longer and some are shorter. That's why it's important for us to know our health. So typically, on average, the uterus lining breaks down and menstruation starts, and that would begin the day one of your menstruation period. And on average, it lasts about 5 days. But again, that's an average. So there's some women whose cycles are longer and some women whose cycles are shorter or either longer. The next phase is called the follicular phase, and all of that's in the green is the follicular phase. So this is when the uterus lining really starts to thicken again, and that's usually on average starts around day 6, and that goes until day 10 on average. The ovulation phase, or the ovulation, occurs usually around day 14. On day 14, this is when a woman can potentially become pregnant. And there's usually a few days within that window of ovulation when she can actually become pregnant, should she choose to become pregnant. After the ovulation phase, the uterus lining begins to thicken, and then we've already entered the luteal phase, and the uterine lining thickening occurs to help with healthy pregnancy. Now, again, if pregnancy doesn't occur, then the cycle begins again, and that lining begins to break down, and the period starts over. So one of the things that I believe that is most important, especially for the young women that are on here and all of us who are at different stages within our cycle, is that we must track our periods. So there's some things that we want to keep in mind when we're tracking our periods in terms of our women's health. We want to think about the frequency of our periods, when they occur, how often they occur, how long they last. We also want to think about the heaviness and the color of the blood. So the heaviness of the period, if there's clotting, if it's really light, if it's a dark brown, if it's not bright red, these are things that we want to also keep in mind in case there's any changes so that we can talk to our healthcare team. The other thing that we want to keep in mind is the amount of pain we may have. Some women don't have any pain with their periods. I'm not one of those women, but there are others that do have pain. And then we also want to think about our emotional health during that time. So how do we track? Some women, like me, I learned very early from my mom to track with a paper calendar. I've since moved to using an app on my cell phone to track when my period comes. And within that particular app, I have an iPhone and it tracks right in the health app, but there are other apps as well. I'm not endorsing one or the other, but find something that works for you to keep track of when your period comes and when it ends. The other thing that I like about using apps is that I can also track what color the blood is, if I've had any pain, if I've had any weird cravings, because for me, I sometimes crave French fries, which might be weird, but that's the thing that I crave when I'm in chocolate, not necessarily together. And I'll track all of that in that same app. And then I always track when my period starts and when it ends. So again, what to track: the start and end dates of your period, or sometimes people will call it your cycle. Describe the bleeding, whether or not it's heavy, moderate, low, or if there's spotting. Any physical symptoms like bloating or headaches or cramp, and any medications that you take during that time. And then for those that are sexually active, also tracking their sexual activity, which relates again to pregnancy. So period hygiene is something that is very important for us to consider. For every woman, it might look different. Around the world, it looks different. When I worked in Uganda, it was very different than the options that we have here in the United States. So in other countries, many times women will create what they call the menstrual cloth, which is a square-like cloth with multiple pieces of cotton fabric that are sewn together that they place inside of their underwear to wear during their periods. Now, the thing with the menstrual cloth is it's not always protective, but for some communities of women, financially, they cannot afford to buy disposable sanitary pads, which are readily available to us, to many of us, not all of us, in the US from Walgreens or Schnucks or things like that, where we might be able to buy them as well. There are also some women who are now going to what they call reusable pads, which is similar to the menstrual cloth, but they're thicker. And they may have, so these pictures are kind of like the reusable pads, where they may have a snap on the bottom so that it can wrap around the underwear, or they might have ribbon or strings around it. And then those are washable, just like the menstrual cloth. And the thought is that these are better for the environment. And these are worn externally in the underwear. Tampons and menstrual cups are inserted into the vaginal cavity. Tampons, they have a string and they're, then you insert it and then remove it from the vagina after a certain amount of time, a couple hours or longer, depending upon the cycle flow. And the menstrual cups, there's different brands. One of them is the Diva cup, and that is also taken out and worn for a longer time frame than a tampon, and then it's removable and reusable just during that part of the cycle as well. So now that we've talked a little bit about our periods, there's one thing that sometimes happens, especially for Black women, is many times we are diagnosed with uterine fibroids. So what are uterine fibroids? Uterine fibroids are non-cancerous abnormal growth that occur in different areas of our anatomy in terms of our uterus or fallopian tubes. And I have a picture of that Minerva will show a little bit later. So about 4.5% to a little under 70% of women may be diagnosed with uterine fibroids at some point in their lifetime. So for Black women, we sometimes tend to have a higher number of fibroids, larger fibroids, and also more severe symptoms than our white women counterparts. Black women are also diagnosed at a younger age than white women. And then we're also 3 times more likely to be hospitalized, and then 7 times more likely to undergo myomectomies. So when it comes to our quality of life, uterine fibroids for many women result in feelings of helplessness, fear, anxiety, and then even overall decrease of quality of life related not to being able to go to work because of heavy bleeding, missing social functions. And then there's even a financial burden that sometimes happens from wanting to receive treatment or management for fibroids. And overall, it's been estimated in the United States that the treatment for fibroids will cost $34 billion. And that estimate is from 2012, and we know it's much higher now.
So I'm gonna go a little over the physical manifestations of uterine fibroids. So if you look at this image, you can see that there's different growths within the uterus. So you could see it could grow on top of the uterus, outside the uterus, within the walls of the uterus, and even inside the uterus. So, and some women may even have multiple of these uteruses in different locations in the same location. And it could go up to ranging about the size of a grape all the way to the size of a melon. So you could see how that would disturb, the daily life of these women, and how the presentation of these could cause different symptoms. So in the next slide, we're going to be talking about the different symptoms. The most common is abnormal uterine bleeding. So this is what we call heavy periods. So this could be even bleeding constantly. So some women sometimes bleed every hour on the hour, or the length of the bleeding. So it could, Dr. Joy mentioned that there's an average of 5 days, but some of these women could go up to 10 days dealing with uterine fibroids. So you could see how that could be an impact. There could also be changes in the color of the menses blood. And given with the abnormal uterine bleeding, some women lead to iron deficiency, so anemia, because that means that they're bleeding so much that their blood's just not having it and resulting in anemia. There's another symptom called bulk symptoms, and this is more common in the fibroids that are on top of the uterus because they're protruding out. So these bulk symptoms could cause pelvic pain or pressure. So with some of these women, depending on the size, you could actually even feel it just touching it on your stomach or your abdomen. And with the pressure of the uterus of the uterine fibroid on the uterus, you could also have bowel dysfunction. So it could even mess up your bowel movements and also the abdominal protrusion. So you could feel it. And with the position of the uterine fibroids, it could also cause reproductive dysfunction, such as infertility, miscarriage, and pregnancy complications. And then Dr. Joy is going to go about the topics and the treatments that we could do, how to better manage these uterine fibroids.
So like many women, I live with uterine fibroids. I'm not afraid to share that story. And for some women, this was not my story, but for some women, they were diagnosed with their fibroids during a traditional pelvic exam during the Pap smear. Sometimes they're found during an ultrasound for a different procedure. So for me, my fibroids were actually found when we were doing a workup for trying to have children during an ultrasound. And so they're usually confirmed by a transabdominal ultrasound, so it's an ultrasound outside of the body, or either transvaginal ultrasound is usually more typical, where they will, where the physician or the radiology technician or someone on the care team, along with the radiologist or the OBGYN, will insert a rod into the vagina to do a transvaginal ultrasound for imaging to see where the placement of the fibroids are within the uterine cavity. Another way that they're sometimes confirmed is also through MRI. And MRIs are extremely costly, so that's not always used until there's a discussion of more invasive treatment options. So how are fibroids managed? For some women, it's a watch and wait. This is where I am with my fibroids, where they're monitored by ultrasound. I do symptom tracking. And then there's also things called decision aids, which is an opportunity for the patient and a member of the care team. So be it a nurse practitioner, a physician assistant, a nurse, or the physician, like an OBGYN or someone in family medicine or internal medicine, primary care doctor, will ask a woman, okay, what are your symptoms? And what are the things that you want to do in terms of your women's health? Are you interested in having children? Are you interested in not having children? Have you had children? Have you not had children? What are your periods like? And then making a decision together on what the next steps would be. For some women, medication is an option. So for some, it might be using different hormonal treatments like birth control pills or different medications like that. The verdict is still out on certain treatments related to complementary and alternative medicine. So if that is something that someone is considering, I would say talk to your healthcare provider as well about that, because we want to make sure that anything that we do complements each other and doesn't cause other concerns later. There are also surgical interventions. Hysterectomy is the only treatment where fibroids will not return, but it is also the only procedure where a woman cannot have a child should she want one later. So myomectomy, radiofrequency ablation, uterine artery embolization, and the MRI guided focused ultrasound are all what they call uterine sparing procedures, which means that the uterus stays intact, but it also means that the fibroids may return. There's a push now for women to maintain our uterus so that we do not have hysterectomies. This way, we don't start menopause before that natural time period that I showed earlier, because once menopause starts, then the estrogen hormones and the other hormones that we produce naturally that impact fibroids will change completely, which means that our health would change, which means that we may not have to have a treatment in the first place. So my suggestion is to talk to your physician, determine the best management and treatment option, and then to look for the treatment option that is going to increase quality of life. In my family, many of the women had lived with uterine fibroids. There are some women in my family who have had hysterectomies, and that was the right option for them. There are some women in my family that had myomectomies and have been very successful with that as well, and have had children since. So really consider what's important for you and family planning and quality of life. So how are we addressing the concerns of Black women diagnosed with uterine fibroids. Minerva, I am going to turn this back over to you so that you can talk a little bit more about your thesis project.
All right, so the way that we're addressing this is we're forming a community study. So working with the community to better discuss uterine fibroids and how we could better manage them and how to discuss it with the population. So the objective of the study, the overall thesis study, is to provide insights to barriers and facilitators resulting in treatment delays in uterine fibroids. So the way that we held this is that we held a community engagement research studio, and this is a facilitated discussion between community members and researchers. So we were able to bring 6 Black female participants to recruit in a community engagement studio online via Zoom, similar to this. And I presented the objectives of the study, what we're trying to find out, and the long-term goals of the thesis. So, better improving discussions between uterine fibroids, how can we open discussions with providers, with family members, and all that. And also discussion of what is healthy menstrual bleeding, because I feel like that's a big taboo. And then Dr. Joy led the discussion with the interview guide that we created. And then we had 3 note takers during the entire time taking notes. And we ended up with about 15 pages of notes, because there were so many quotes, so much information that's going to be implementing. And we identified these notes by using Memoly, and that would identify common themes that we're going to talk about later in the research process. So the main topics of discussion is that we want to talk about menstrual health literacy. So what are things that we should bring up with women to discuss about the menstrual health? What type of topics? How do we bring up this conversation? Because in some cultures, it is still considered a taboo, and I think that's what's causing some of the treatment delays, which leads to the cultural impacts. How can we better facilitating and opening these conversations? And then what are the best approaches also for recruiting Black women into medical research in uterine fibroids? And that's an interest because for my thesis topic, I'm interested in focusing on Black African-American women and also Hispanic Latinas. So how can we get that population to be open and participate in this research? And then at the end, we ask for final reflections, which is what is something that you want to tell us before we go? Any last minute things? How can we help? What did you wish you would have known in your uterine fibroid journey? And so at the end of this, we ended up with a few main topics and themes. So one of the main themes that we found was conversation facilitators. So many of the women that participated in the study talked about having an open discussion with their healthcare teams. So talking about being honest with your healthcare team, like how long are your symptoms? What are you doing? This goes back to knowing your body and knowing when something is wrong. And then also having this conversation with family members, like Dr. Joy mentioned, that her family members have had history of uterine fibroids. So bringing that awareness to the next female generation that is coming up. And some women mentioned that there was also misinformation and myths. So that there was a lack of information of how uterine fibroids are being grown. And even in the scientific literature, nobody really knows what's causing uterine fibroids. There's a bunch of theories everywhere and it's still not known. So that confuses us patients when they're going to Google search and assume that it just happens out of nowhere. It might be diet. For some women, it could be treated with diet, but sometimes it's not. There's different causes for things. And so goes back to not even every treatment is applicable to every woman who's diagnosed with uterine fibroids. You have to see which is the best fit for you and if it works or if it doesn't. And then another thing we discussed was alternative treatments. So this goes back to what Dr. Joy said. We're talking with physician if you're thinking about doing alternative treatments. There are some out there that might be effective for some women, but it's not going to be effective for all women. So knowing your body, knowing what's out there, and even just giving it a try, but you might have to go to medication routes or surgical interventions. And then the last thing they gave us was going with the recruitment is how can we recruit the population of interest? And they gave us suggestions of reaching out and developing partnerships with professional organizations, faith-based groups, and clubs.
So one of the quotes from the community engaged studios. So the studio was held as a way of a starting place before we do a larger national study. We're planning to do another studio with women that are Hispanic, Latinx women as well in the next few weeks, because we want to hear from both groups. So one of the quotes that really stuck out to me from our notes, we did not audio record them because we wanted to maintain a level of confidentiality and to give women a chance to kind of share with us in more of a conversation, almost like a fireside chat. So Black women think that it's normal or acceptable to have heavy or painful periods. Guess what? That is a myth. That is not true. If our periods are heavy or painful, then we need to talk to our healthcare providers. So there are other health concerns related to our periods. Endometriosis. I was diagnosed with endometriosis at 40. This impacted my health greatly. I had very painful periods and also had uterine fibroids. It impacted my ability to maintain pregnancies. And then a short surgery changed my periods. You know, everything changed once I had surgery for the endometriosis. Endometriosis has become more of a topic more recently. I think it's Gabrielle Union. She spoke about living with this. This is another form of women's health problems. PCOS, or polycystic ovarian syndrome, is another disease that is linked to women's health. Amenorrhea is the lack of a period, and there's primary and secondary, which have different symptoms, and dysmenorrhea, which relates to the painfulness and severity of our periods. So our call to action is knowing our bodies. We must know every change, everything that might occur, from our breast health to our periods to even just our overall emotional, mental, and spiritual and physical health. I sometimes say to avoid looking at Dr. Google, because Dr. Google will take you down this wormhole of information, some of which will impact further myths. But speak with our healthcare professional who have knowledge of women's health. And then it's okay to seek a second and sometimes a third opinion from another healthcare provider. There are tons in the St. Louis area who will be willing to talk to you. And I believe in that strongly. And if available, speak to biological females and relatives and even colleagues and friends about their reproductive health and the things that they've done to stay healthy and to know their bodies. There is no shame in talking about periods. There's no shame in talking about sexual health or reproductive health. There's no shame in talking about living with fibroids or endometriosis or the other things that I spoke about. Instead, we want to empower each other to have these conversations starting early. So some of the other things to keep in mind, our physical and emotional health, as well as our spiritual health, are extremely important in order to maintain our quality of life. Finding a way that works to track any changes to our cycles or our period, and then being willing to talk to a healthcare provider. Many times when you go to the doctor, the first question they'll ask you is what was your last period? And that is one of the reasons it is very important to track. And then they'll sometimes even ask you, how long is your cycle in between your periods? So that days, is it 28 days? Is it shorter or longer? And things like that. So again, I'd like to thank my sorors, my friends, my colleagues, and family members for being here today, and for each of you. I want you to find ways to track your periods, because that's important. And for those, I don't know if there are any big brothers or dads or husbands or partners who are on here who do not have periods, to encourage your biological female sisters, sister friends, and colleagues, when they want to have a conversation about their women's health, to be willing to listen. And then when changes occur, speak up, and to continue to encourage each other. Feel free to follow me on social media. I'm on Twitter, and I talk about health, food, and faith. And I'm also on Instagram. Thanks so much. And I'll take questions.
If you would be so kind as to put your questions in the chat, we will monitor in that way. I will be more than happy to read those questions. And while we wait for you to do that, I want to again thank Dr. Joy and Dr. to be, Minerva, you know, you have to speak things as if they are. And for providing us with what could have been new information, refresher, and things to remind us to follow. With there being all these women on here, I know that they're going through the same thing. Women, we have this in common, not necessarily fibroid issue, but some of us do have that. And it's amazing how frequently you hear about how prevalent fibroids are in African American women. So again, I'm going to take a look in the chat, and I'm going to read one question, aside from the fact that people are giving kudos, and it's very much warranted. But the question that's in here is PCOS and endometriosis hereditary?
So there are some, okay, so I will preface this. So my colleagues that are physicians and OBGYN, if you'd like to chime in, feel free. So there are some thoughts that there might be some hereditary links. I'm not as familiar with those as I am with the links in terms of some of the genetic factors related to fibroids, because one of my mentors actually helped to identify the genetic links with uterine fibroids. And so for me, Mom, I'm about to out you. My mother lived with uterine fibroids and had a hysterectomy. And I know she's looking at me like I'm crazy right now, but that's okay, because she had already decided that I was it in terms of babies. So, so there's that. But in my family, I was the only one that experienced endometriosis. So for me, it was not necessarily a genetic factor. And the fact that it was not caught probably in my 20s, because they stage, and endometriosis is staged in a similar way as cancer is staged. So, you know, so for me, I was stage 1 with my endometriosis, almost stage 2. And I was living with chronic pain to the point that my OBGYN surgeon said, I don't know how you're functioning after the surgery. And so it is really important that, and I work in the health field. I was going to my yearly checkups. But it took me finding the right physician after talking to others to figure out what was going on with my health. So I hope that I answered the question. Mrs. Gage, are there other questions?
Miss, and has the age for menopause gone higher over the years? I've been hearing about ladies achieving menopause after 50, which was a bit surprising when I discovered this. Do you, it's a two-part question, so I'll start there and allow you to answer that part, and then I'll share the second part.
So in the literature, in the scientific literature that I've been reading, I haven't noticed a change in the start phase for menopause. Minerva, have you noticed anything?
So there's a relationship between starting your period earlier and actually entering your menopause later in life. So I think that's what's going on, because we do hear a lot of young girls now starting, menstruating a lot earlier. So there's a relationship between that. It's not really known why, but I'm pretty sure it might be the environmental factors. But there is like association between a relationship between that. So that's why a lot of women are now entering later in menopause.
See, I knew she would know. I have her reading more literature than me. The beauty of being a PhD student. All right, what's the second question?
It says, do you think that the growth hormones in our foods and dairy systems have impacted menstruation in any way for young ladies or even for middle-aged females?
Minerva, you want to take it? I see that that you're smiling.
I think I haven't delved up much in that literature a lot, but I do see like there's a lot of associations of things that we eat. I know for sure like BPA was a big thing, and that's why we always had to check with the plastics that we do, because BPA mimics a hormone, similar to estrogen. So it means that you're getting a lot of estrogen in your system, which is actually causing an increase in everything else in our system. So there is a little bit of a relationship between, at least with the use of plastics, and that's why you have to be careful if you put in the water. Like if your water bottle's in the sun, then the plastic flavor goes in the water. You don't want to drink that water. So there's a lot of things we have to take in consideration. I know there's a thought about food, but I haven't delved into the food and the antibiotics and the growth hormones that we eat as much to see if there's a cause for that. But I know that's definitely a theory that's going around.
Yeah, and so there's not a lot of information just yet because it's still theoretical and in practice, which means that we need more funding and opportunities to study those impacts as well, potential impacts. Kay, you're muted.
We have two more questions. The next one says, is it considered abnormal to reach menopause in the late 40s?
So typically, on average, most women start perimenopause around between 45 to 46, 47. And so, so like for me, for instance, I just had my visit with my new OBGYN, and we talked about the fact that I'm now in my mid 40s and if there's any changes. So most of the time, menopause is diagnosed with the absence of a period for over a year. So the period has to be gone for 1 year for menopause to be diagnosed. And so that's one reason that we say to track our periods, because we need to know, like, you like say, oh, like I went to the doctor and I was like, God, I haven't had a period in like 40 days. I said, this is a problem. And so I went to the doctor and he was like, stress, and you're now in perimenopause. Welcome to perimenopause. And I was like, awesome.
Confetti.
I know, right?
Fireworks.
It's like, fireworks. I was like, this is
the things we find joy in.
exactly.
The next question. We don't hear healthcare providers discussing the link between fibroids and estrogen dominance. Why is that?
I wonder, and I'm not a physician, and I wonder if it's because we haven't developed the appropriate lay language around having conversations about hormones. So Minerva mentioned menstrual health literacy. So when we talk about functional literacy, that's our ability to read and write. Health literacy is our ability to understand health information that occurs, right? That we're provided or that we're reading or that we're looking into or videos that we might be watching. And so I wonder if there's a disconnect in the materials that are created that are provided on estrogen and other hormonal aspects as well. So I just got another question via text related to another one. May I ask that one now?
Of course.
All right. So the question came up about whether or not starting menopause in the late 40s. It goes back to that original question where healthcare provider actually mentioned to one of the women in the audience who I actually know, that's why the question came up on my phone, starting in late 40s, 47, 48, if that was normal. Again, everything is an average. So you're going to have people that will start menopause earlier, which might be in their 40s, and some that will start later. So I don't think that it's abnormal, but what I do believe is that it's very important that when these changes occur, that we may need to talk to more than one healthcare provider just to make sure that there are no other concerns as well.
Did you get another one on your phone? I saw you looking.
No, that was a thank you.
Oh, okay.
That was a thank you because they clarified
Okay.
the question, and I won't call them out, but thank you so much, friend.
Yes. We're all friends. Okay, the next question says, how does having sickle cell trait affect menstrual cycles?
I'm not sure. So I'm one of those scientists that is not afraid to say that I am not sure. I do think that we would probably need to speak with someone that is an expert on sickle cell anemia as well as sickle cell trait. Because women are living longer with both. The average life expectancy has changed quite differently from 20 years ago. So I do think that it's very important that we speak with someone who specializes in oncology, as well as OB-GYN and even reproductive endocrinology as it relates to sickle cell anemia or even sickle cell trait.
Thank you. We are getting some good questions. Oh my goodness. This one says, much needed conversation. Thank you for having this forum. You're welcome. I had a hysterectomy at 50 with years of heavy periods and numerous fibroids. Is there any self-care that I should be doing post-hysterectomy? I am now 55.
So I do think that there is the need to still speak to your healthcare provider. There are still other things that can occur related to women's health that are not linked to hysterectomy, even things like different types of cancers and things like that as well that are related to, which we did not cover today. So I do think that that's very important. I also think that it's important to really think about emotional health as well as spiritual health, because what did you say, Mom? My mom is saying something else about, she was like, yes, all of these things. So she's co-signing what I'm saying. And so I'm thankful for that. But I do think that, it's still important to see your OBGYN to talk about other changes that might be occurring within the body as well, even post-hysterectomy. And there are some studies that are coming out that are looking at uterus transfers, like transplants for women that have had hysterectomy so that they can eventually have children, because there are some women that have hysterectomies very young in life, in their 20s as well, who still desire to have children, but once the uterus is removed and the ovaries or either one or two are removed, then that makes an impact as well. So I always say when it comes to hysterectomy, if there is a potential desire to have children, that it's also important to speak to someone that specializes in what they call reproductive endocrinology, which relates to fertility, to see if there's some things that can be done for egg harvesting and things like that, if someone should choose to have children later.
We have two more questions that I think we have time for, because our time is drawing close. Oh, there's another one. You all are so slick. You're so slick. It says, Dr. Joy, will you discuss HRT therapy?
I would if we had time.
Oh,
so,
because it calls for a whole discussion.
That probably would be a whole discussion. And they were talking about hormone replacement therapy. This is used not only for women that go through menopause, but women that go through fertility treatment. I do not shy away from my fertility journey because I did have to use hormone replacement the last time. We've had multiple miscarriages and I had to use estrogen and all these other things and a bunch of shots in the belly, and all of that affected everything. So like everything is different now. And there are some, when I had to talk about perimenopause recently with my physician, we did talk about hormone replacement therapy, should certain symptoms change for me, and whether or not that's something that I'd want to use. And sometimes that might be birth control pills, sometimes that might be estrogen replacement. And then there are other things as well, but we'd have to have an hour to talk about that or longer.
So there are actually three questions. They are, this is clearly a much needed discussion. And I'm going to do what I can. We're going to we take just a little bit more of you all's time. If we go over, please charge it to our heads. Really not even our heads. Look, we need to get some questions answered. Okay. So there are three that I want to, especially those that have come in via Facebook. But this one says, you mentioned fibroids are staged like cancer, but fibroids are non-cancerous, correct?
No, I mentioned that endometriosis is stage like. Yep.
Okay. Thank you. Now from Facebook, it reads, I have grown children, youngest 29, oldest 31. I had an incontinent cervix. My oldest was a preemie, my youngest was high-risk pregnancy when I was 25. I will be 55 in a couple of months, almost at menopause, but dealing with my cervix dropping daily. Would a hysterectomy at this stage be an option for this problem?
So what I will say, again, I am not a physician, but what I will tell you to do is to talk to your current physician. And if your current physician is not able to answer your questions, talk to another one. You know, and if you still aren't getting the answers in a way that relate to what your quality of life, talk to somebody else. You know, there is no shame in changing healthcare teams. There is no shame in having these direct conversations, because again, if the cervix is shifting or changing, that is uncomfortable. And I would not want you to live in a place where you do not have good quality of life, because your quality of life is the most important thing.
Absolutely. Ladies, if we will go buy another pair of black shoes for that same reason, certainly we can give thought to changing our physicians. You get one life and one life only. And to our last question, have you heard if the use of tranexamic acid tablets? Have you heard of the use of let me spell it, TRANEXAMIC. Is that tranexamic acid tablets?
I'm
Thank
not
God for science.
and I probably would have pronounced it wrong, because, you know, I like I said, I live with dyslexia and I might have been saying it all over the place. So I have heard of it. I'm not as familiar with it. Minerva, did you want to speak to that?
Yeah, so I think something that we forgot to mention in the talk is that the treatments for uterine fibroids, they're all about the symptoms, mostly for the abnormal uterine bleeding. And tranexamic acid is actually one of them. So it just deals with, you know, your abnormal bleeding. It doesn't deal with the fibroid itself. It doesn't slow down the growth, anything. So it's kind of similar to birth control. It just stops you from bleeding heavily. And if it improves your quality of life, it is what it is. But it would also be a discussion with your healthcare provider about what kind of treatments you want, if you want to get rid of the symptoms versus the fibroid, if you want to have kids. You know, it's a bigger discussion, but I have heard of it. But it just treats the bleeding itself, not anything else.
So another question came via text, and the question was, I got to unlock my phone, was, is it safe to modify the timing of your period with herbs or birth control, like to delay 4 weeks? So there was some literature very early on about delaying the cycle and only needing a certain number of cycles per year for women and being on extended birth control. I'm unfamiliar with using herbs. Again, I'm very cautious when it comes to using certain remedies that we can buy over the counter without talking to our healthcare providers about it, because again, we don't want there to be any interactions with certain things as well. So my thought is to talk to your healthcare provider more closely about whether or not the hormonal treatments will work. So for instance, when I had the recent conversation about perimenopause, one of the things that we discussed was having going on long-term birth control pills and just staying on them for a while. There are some women that will use an IUD that releases hormones in order to prevent symptoms from menopause as well. So I think that that's a bigger discussion with the healthcare provider. Okay, you're muted.
I want you all to know that this has been a very robust discussion. It's been meaningful. And I'm hoping that you all leave with something more than what you came. At this time, we're going to ask that you complete a survey for us. I bet it's going to pop up as a poll. I just bet it is. See, And so we're going to have you to complete this survey really, really quick. And after that time, you are going to hear from our Vice President, Ms. Bethany Williams. I want to say that it has been a pleasure to be with you this morning as your MC. And we hope that you will find other activities that are sponsored by Gamma Omega that you will find will be worth your while.
Well, I will say thank you for joining us today. Like Kay Gage has stated, this has been a very robust conversation, a conversation that is needed not only in our sorority, but women all over the world. And it's good to be open and honest with these conversations. And so, like the topic says, girl talk. It has to come to a point where this becomes everyday normal conversation, and young ladies of all ages feel safe and comfortable having these conversations. So 3 takeaways from today. Know your body. It's very important. Track your period. Speak up when changes are happening to your body. Those are 3 takeaways that every girl, every woman on this call should know and monitor on a daily and monthly basis with our bodies. We're all busy, we're all stressed, we're all of those things and more. But those are 3 things that we should every day center ourselves to know and love our bodies. I want to say thank you for joining us, Gamma Omega Chapter and the Ivy Alliance Foundation. Thank you to our panelists. Thank you to our hostess with the mostest for joining us today. And have a great weekend and continue to follow us on social media for more events, more engaging topics. And on April the 1st, HBCU for Life virtual tour. Thank you and enjoy the rest of your Saturday.